Okay, well, welcome back everybody to the second of what I hope are our short, sharp sessions. I'm not normally a chap that wears his jacket suit all the time, but that's a bit chilly, isn't it? We have had a word with the building management and they are turning up the temperature, so for those that are feeling a bit chilly in that first session, hopefully we'll put that right in the next 10 minutes or so. So I'm still looking for just a bit of hush so that we can get started and focus on the next session. So, next section now on research, and what we're going to ask first is for Sonya just to briefly outline the Action for ME research strategy, and then we have two more significant players in the research field, and what I'm going to suggest we do is that we listen to all three presentations and then we have a question session afterwards. So Sonya you've already met. Derek, to my immediate left, Professor Derek Pheby, has a long history of fostering both research and changing professional and public attitudes on ME, from the National Task Force on ME in the early 1990s through the Chief Medical Officers Working Group to the MRC Expert Group. Derek was also the principal investigator and product coordinator of the ME Observatory Project and is a trustee as well on our board for Action for ME, and is the principal investigator for the UK CFS Disease Register, which is co-funded with two other charities and a private donor. So he will talk immediately after Sonya. And to his left is Dr Luis Nacul. He's the chief investigator of the Cure ME Research Group based at the London School of Hygiene and Tropical Medicine. His team collects and study examples for the UK's first ME Biobank, which was co-funded by Action for ME, which allows biological samples from people with ME to be stored for future research. He's a medical doctor by the University of Sao Paulo, has a PhD in epidemiology from the University of London, he's a consultant in public health and a specialist in family medicine, and I just can't come out with any more. There's just so much of it, Lewis. But we're very impressed and delighted to have you both speak. But first, I'm going to ask Sonya to say a few words about the ME research strategy. Thank you.
Notice Alan didn't say he was impressed and delighted to have me here, so I'm feeling a little bit upset. He did remind me I was talking again. I had forgotten. So I'm just going to say a few words about our research strategy, because we've been on a bit of a journey with our research work, and we've been really delighted that the investment in pilot projects is really paying off in terms of attracting mainstream funding, and we saw that with the Biobank, with the $1.5 million that's come from the US. I mean, that's just unheard of and is really fantastic. And I'm quite confident that some of the other projects that we're funding will go on to attract mainstream funding too. So we have we reviewed our research sort of policy recently, and our intent is to fund biomedical research. And we recognise the role of other research and different types of research, but we've just put out a call for biomedical research projects at the moment, and that's really where our focus has been. And we know that there's a lack of funding in this area, but we are working really hard to try and increase the investment in every way that we can, and that's why things like this visit that I referenced earlier are so important. So we're in the process of developing our research strategy, and we're going to invite you this afternoon to play a part in that. And I'll just say a little bit about the process for development. We have been working with a number of stakeholders to help us think about what our research strategy should be. We've talked to a number of people, and some of you may have participated in our research priority survey. We had nearly 1,000 people, and Stephen put some quotes up earlier on that helped us identify what people's priorities are. We're trying to be more transparent, and we now have some criteria, a set of criteria that we use to help us determine whether or not we partner in research projects. And I'm not going to mention any names here, but we've had a lot of criticism about projects that we've been involved in the past, and we want to make sure that in the future that we are very transparent and clear about why we're getting involved and what benefit that gives to people affected by ME. We also need to know what the impact of our work is. So our research strategy has to have some clear outcomes included in it. So just in terms of the research priority survey, the survey was very quick. We didn't have much time. The UK Collaborative wanted to hear what our priorities were, and we thought, why are we putting that forward? Why aren't we going out and asking people what their priorities are? And we're now replicating that with researchers, so we can see what the gaps are, what the similarities and what the differences are. Over 90% of people that responded in the survey had ME, and that was really important. Has ME, sorry. That was really important for us to know that. So this is the graph. You can probably read them up there. And we all of this information is on our website, on our online ME centre. So if you want to know a little bit more, you can go and have a look at that. But it was really clear that there were a number of key priorities. And what we said, rather than looking at the first, second and third priorities, which is what we asked people to identify, we put forward 5 because they really stood out. And you can see that within the graph. So the top 5 are highlighted here in orange, and I'm not going to say you can read those there. They were put forward to the collaborative, and Stephen and others are working on those priorities along with AIM's priorities, the ME associations, ME Research UK's and the other charities that are involved. And we will come up with a set of priorities for the collaborative, but actually we're going to be using these to inform our research. We have used these to inform our research strategy as well. So this is the big unveiling, and this is where we are at the moment. This is not set in stone. This is the starting point, and you have got a copy of this on your table and are going to be talking about this afternoon. But what we've set out is that our vision, our new vision, is a world without ME, and the goal is personalised medicine. And it was great that I didn't know what Stephen was going to say, but that is our goal. We need to be working towards that. And our priorities are the severely affected, and just over break, talking to Natalie and to others, there is not enough research being done with severely affected people with ME. There is just not enough, and we have a role to play in helping to fund that, to inspire that, to encourage researchers to get more involved in research in that area. Diagnosis, targeted treatments, and cause and prevention. And we've identified 4 themes from all of the discussions that we've had, which are disease processes and mechanisms, genetics and genomics, biomarkers and epidemiology. And that really fits, I think, with what Stephen was saying earlier on. And to continue the tone of our statement of strategic intent, there are 5 promises that we have. That we will innovate, we will stimulate, we will collaborate, we will participate, and we want to work so that research is translated into practice, into treatments, into the service that people with ME get. So I'm not going to say too much more about that. You are going to this afternoon have roundtable discussions focused on this, and I'd be really keen, whether it's today or afterwards, for you to come back and share your thoughts on this. We are going to consult with our supporting members and with others before we say this is our research strategy. We want it to be owned by our membership, and we want to get this right, and it will change over time. This is a starting point, so please do share your thoughts and views on it either today or afterwards, as I said. So I'm now going to hand over to Derek, who's going to give the first of our presentations.
Very much so. What do I do to make this machine work?
You can press that one, or you can use...
Oh, I see. Oh, I can use that. Right. Okay. Thank you very much. Well, thank you very much, Sonya. Thank you very much, Alan. I was going to talk a little bit, not at very great length, about the ME Disease Register that we're in the process. So we've piloted. We're in the process of setting up a new at the Buckinghamshire University. Remember, this was one of the sub-projects within the Observatory project. So just to recap, the Observatory project was running from 2007 onwards, and we set this up originally because I was very concerned that why we knew so little about ME compared with the area I was working in before, which was cancer. There seemed to be an awful lot of work going on, but it didn't really amount to a substantial corpus of knowledge. So what we So it seemed to me there were some specific gaps that we could fill, and so we did work in epidemiology and in qualitative social research because that's what were the areas of interest of our collaborators. But also there was a need to set up a range of infrastructure facilities to support research, because that's one thing which was missing, which was really very highly developed in cancer, which was perhaps part of the reason my knowledge of cancer is so much more advanced than knowledge of ME. So this was funded for 3 years by the Big Lottery Fund. It was sponsored by Action for ME, and it was an academic collaboration of 3 universities, the London School of Hygiene and Tropical Medicine with Lewis here, the University of Hull and the University of East Anglia. We produced 6 scientific papers. There are more coming, various sort of spin-offs from the project as we get the work finished. And there are 2 ongoing projects. One was the Disease Register and one was the Services Directory, both of which I think have a continuing role to fulfil. So the pilot study under the Observatory project set out to recruit participants with ME in an unbiased way from a large population base, because I was concerned that many of the studies, for example, intervention studies which have been published, have been on people attending a particular clinic, which of course presupposed that people would get to the clinic in the first place. So substantial numbers of people with ME were excluded from this sort of research, and yet people would take the outcome of this research and try to extrapolate it to the whole ME population, which really doesn't have any great validity. And also, we wanted to look at prognosis, to create a cohort for long-term follow-up to shed light on prognosis, because despite all the effort that's been put in, we really know very little about outcomes and prognosis in this condition. And it could also act as a sampling frame for other studies, like intervention studies, where we could get away from the problem of people attending a single clinic being involved in the study, and perhaps produce groups of people who are more representative of the ME population, or of particular subgroups of interest within that population. So we worked with 29 GP practices and recruited, covering a population of nearly 150,000 people, and we identified people with unidentified chronic fatigue using an algorithm based on the coding system used in GP computing systems. And then we developed other algorithms in our system to identify conformity to case definitions. And we use the Fukuda definition, not because it's any good for epidemiology, because it isn't, but because this is it was the only show in town at the time, and if we wanted to make comparison with previously published work, we had to use the same definitions. But we also used the Canadian definition, which was much more specific. So we had the advantage of the sensitivity of one definition and the specificity of the other. So all in all, we found we recruited a total of 160 people to the register that way, and most of whom conformed to the Fukuda definition, and roughly half of these conformed also to the Canadian definition. And there's a reference which you've got in your pack if you want to read the paper. All our papers are published in open access journals, which can be downloaded free of charge if anybody wants to look at this. So the current project is intended to transfer the DME disease register to Buckinghamshire New University and to implement a research programme based on it. We intended to recruit a cohort of people with ME who could be followed up, as I say, in order to investigate prognosis and constitute a sampling frame for other studies. And this is where I owe people an apology, because we've really been quite slow to follow up the numerous people who volunteered to participate in this, partly due to the complexity of setting up the project, partly due to personal matters not unconnected with my own 30-year battle against medical ignorance and arrogance. So what we want to do is expand the register to follow up existing participants, including the people who participate in Chrome, who we've already incorporated into the database. Again, the Chrome project was in the process of winding up, and we felt this was an invaluable resource where we should continue follow-up for longer if we could. So we contacted all, with the agreement of the Chrome trustees, all the people who had participated in Chrome. I suppose everybody knows what Chrome is, isn't it? It's a database of people who are all either housebound or bedbound with severe ME, at least at the point of recruitment. And 160 Chrome participants agreed to continue to allow us to use their data and to follow them up through the disease register. This project will also be linked to the Biobank, of which Lewis is going to talk in a minute. So if we incorporate the Biobank participants in our disease register, we can then do long-term clinical follow-up. So we'll end up with a very powerful tool with biological specimens being held by the Biobank, which can be linked to longitudinal clinical histories, and this gives us quite a powerful tool for research. And another project which we'd like to pursue is to develop a post-mortem tissue archive, which I'll talk a bit more in a moment. So why is it useful? Well, we're setting up a central infrastructure facility, and I see this as part of a strategy to bring greater coherence to the whole research endeavour in ME, which we hope will contribute to developing a more comprehensive corpus of scientific knowledge of the illness. It's linked closely with the Biobank, as I've already suggested. And it's a 12-month project. It's been funded by the ME Association, Action for ME, and ME Research UK jointly. And so we have a series of milestones which we hope to achieve over the course of the next year. The project, the 12 months, is only just really getting underway now. We'll have responded to all of the people who've contacted us wanting to participate by Christmas. We'll have then got some more information from people and asked them to fill in various questionnaires about symptoms and so on, so that we can check conformity to case definitions. We'll then, we've got various papers we want to draft during the course of this project, and finally we'll be producing a report at the end of it. So what next? Well, we hope this will lead the way to an expanded academic collaboration. We want people to actually use this disease register as a research tool which is available for bona fide scientists to use. We'll be enhancing it. I've already mentioned the Biobank as a related project, and the post-mortem tissue archives, which is something we have on the stocks, as it were. I've spoken to Dominic O'Donovan at Cambridge about this. He's been collecting a few cases, but the trouble is most people with ME, we're very glad to say, don't die particularly quickly, which is obviously a very good thing, but it means if we want to develop a post-mortem tissue archive, it's going to take a long time to develop a suitable critical mass of tissue to make this useful. So I'm just wondering whether this is something which we could be pursuing on a European level, because we accumulate a mass of tissue rather more rapidly from a population of 500 million than we can from a population of 60 million. But obviously that raises a lot of ethical and legal questions which we have to resolve as well. There are post-mortem tissue archives in other locations, and Luis has looked into the one which exists in the United States. There are problems. There are logistics of specimen handling. There's a question of cost and time I've already discussed. But as I say, we shall be following this up. We've got one paper which has been published, and these are the conclusions from that paper. I won't read it out in detail because it's all in your pack anyway. And we've got another paper which is a detailed protocol for such a post-mortem tissue archive, which is currently going through the peer review process and will hopefully see the light of day as a published paper relatively soon. And that's the reference to the paper which we've already published. Again, the reference is in your pack. So, conclusions. We think ME may not be quite as common as has been asserted in some quarters, but the various guesstimates which are around are not out by an order of magnitude. We need to clarify the epidemiology of ME, both for its scientific interest, but also by demonstrating in a scientifically watertight and valid way the numbers of people affected. We might have more impact on government and funding bodies and so on who fund both services and research. Epidemiology can help to identify risk factors, and that can lead us towards underlying disease mechanisms, which is what, as Stephen said, is what we need to do to identify the underlying disease processes and the phenotypes involved in this condition before we can really get to grips with it. And there is a role for developing infrastructure in order to enhance research capability to enable us to do this. So that's really what I want to say about the disease register, and I'll hand over to Luis now. Let's talk about Biobank. Thank you.
Thank you, Derek. Thank you, Alan and Sonya, for inviting me to give this presentation today, and very especially for the support you have been giving to our research. Our ME group at the London School of Hygiene and Tropical Medicine is situated at the International Centre for Evidence on Disability, or Disability Centre in short, at the Clinical Research Department. This location tells about what we emphasize. We emphasize clinical research and epidemiological research as well, which is translatable into better prevention, diagnosis, and treatment of disabling diseases such as ME. One of the good things about being part of London School is, as the main and larger public health institution in Europe is that we have direct access to a range of experts in fields such as infectious diseases, immunology, genetic epidemiology, mathematics, and all the omics that Professor Holgate mentioned in his presentation. We have been working in partnership with Action for ME since the project, the Disease Register and the Observatory project that Professor Pheby has just mentioned. And this enables to show that the quality of life and the functional status of people with ME is severely affected. If you look for men and women, it's a similar pattern. If you look in the top for men, there are 8 dimensions of quality of life, and the top blue line represents normality. And then we have people with cancer, with depression, or rheumatoid arthritis, which are quite disabling diseases in the middle. And at the very bottom, you see the functional status for people with ME, which is much lower than for all those other disabling conditions. We are also able to show that the quality of life of people with ME directly correlates to the quality of life of carers for those people, carers of people with ME. So it's very important that ME is not a disease that affects individuals only, but affects their carers, their family, in many different respects. And we're able to develop a model to explain the determinants of quality of life in people with ME, which is related not only to the nature and fluctuation of symptoms, but also to other factors such as socioeconomic status and to a range of factors that such as the availability or lack of availability of networks of support. But this presentation is about a biobank. And that's the definition of biobank, is a storage facility used for biological samples at low temperatures. We're talking about -80 or to -135 degrees for future use in research. These images are from Royal Free Hospital UCL Biobank, and that's where samples from our donors are stored at present. So what is good about a biobank? Why a biobank? One aspect is a very cost-effective way of enabling research. So we have well-characterized cases of ME as well as the controls, both with multiple sclerosis and what we call healthy controls. And we characterize them clinically very well, and then we have samples collected and frozen very quickly after collection. So if it's, say, in 2 years' time, a new technology appears, or even in 50 years' time, or 20 years, whatever, or a new research hypothesis appears, the sample is there, the patients are there, well characterized, and this resort can enable research to happen quickly and very cost effectively without the need for new sample collections. But one main reason why we set up the biobank is because you told us to do that. When I say you, I'm referring to people with ME, and I know not all of you have ME here, but a good number of you have. And we have a quite participatory approach to research, and then we listen and discuss with people with ME and a range of experts from academics, health professionals, people with expertise in ethics, law, etc. So we try to listen and discuss with many people, including especially people with ME, about what they thought about research, what research priorities were. And this is a quote from one of the persons with ME during one of our group discussions. They say, "We feel sort of powerless and so much is taken away from your life." I think that it might have a good psychological impact if people felt like they were able to do something positive. Because it made me feel, just coming here today, coming to the meeting we're holding, that I might be doing a little bit. So people with ME have been let down by the establishment, and they are very keen to do something, to be part of something which is positive. This is a way to empower them and to feel that they are doing something good. But we are alerted by a number of concerns. If you look at the top quote, if you're trying to get as much people as you can, they're afraid of what you're going to do, whether the government will get hold of it, whether insurance companies or benefit agents would use it. So there are concerns, and we need to be careful what we do and how we do. And this brings the need for a trust relationship between researchers, health professionals, patients and their carers. And if this good relationship can be established, and if people can perceive good research being done with high quality methodology and with respect to ethical principles, then the vast majority of people with ME that we have listened to, we have discussed with, would favor the creation of Biobank as we did, and are very much willing to donate blood. And this is represented by the quote on the bottom, which says, if we say, come on, we're doing some research, and if we like a blood party. And indeed, we receive many requests for donation of blood, and I'll get back to that in a short while. As I mentioned, we also listen to a range of experts, and this is a nurse, and the top is a quote from a nurse practitioner, specialist in ME, which confirms the concerns that some people have. There is a big issue around trust and to some extent power. I think there will be anxieties about handling of the material and what it will be used for. So this brings again the same question. You need a relationship with trust. You need to have a robust methods and robust ethical principles governing the handling of the biobank. And although the vast majority of people we listened to were very much in favor of biobank, there were some a small number of people who would think that perhaps this would not be a particularly useful undertaking. So we've been talking about ethics, the importance of ethics, and if we go up to the fourth line, they just refer to the different types of approvals we need before we start in such a project with Biobank. So we need local and national ethical approvals from the NHS if the research is carried out with the NHS. We needed, and we have, the London School and Tropical Medicine ethical approval. And then we need to have a human tissue authority license to do that, and the London School holds a license, and so does the UCL Royal Free Hospital Biobank. So we're covered by the Human Tissue Authority. And of course, Biobank is not just about getting some blood and put in the fridge and then using, or in a freezer and then using later on. It's a much more complex than that. And patients need to be ensured not only by all the layers of ethical approvals that we go through, but also by the fact that they know what they're consenting to and they can withdraw at any time. This is very important. And as important as that any donors will remain anonymous. So we have good clinical information about them, we have good samples, but they cannot be identified. This is very important as well. Many people, as I said, come to us trying to donate blood or offering to donate blood, and we really appreciate that. We are very pleased with this level of offer that many people bring, but we have some quite strict procedures for the recruitment of people, both with ME and also those who are part of our control groups. So one aspect is, of course, we have a limited capacity. We can recruit as many patients as we have funding for. But also, we're very keen that all patients that are recruited have a firm diagnosis of ME, given by either GP, especially services, or coming from the disease register that Professor Pheby has just mentioned. And so consent is given, and after that, we provide a clinical assessment, and we collect some, so we do the clinical assessment, and we collect some bloods, and this is to ensure that people really comply with the diagnostic criteria that we use in research, and we don't want to include people who don't genuinely have M.E., which generates cases of confirmed M.E. by Canadian or Fukuda criteria. We have, of course, the controls, and then we have non-M.E. CFS chronic fatigue group, which may represent people who, during the investigation process, are found to have some exclusionary conditions, and also people who have chronic fatigue syndrome but don't have ME. And then very importantly, the bloods are used, a small amount of the bloods that we take are used for these lab tests for confirmation of diagnosis, but the majority, or the vast majority of the volume of bloods that we have are processed at short time after collection and then stored in the biobank. So far, we have been able to recruit around 180 participants. Most of them are cases, and they come from different sources. I'm not going to go into detail into that. And for each participant, we store a range of blood subproducts: whole blood, serum, plasma, red blood cells, peripheral blood mononuclear cells, which are important for some types of studies, such as those in immunology, and we also do preparations for RNA extraction. So we are able to do a range of studies, from biochemical studies to genetic studies. We have DNA, we have RNA of those people stored. So it's a wide range. We plan this to enable a wide range of research studies to be carried out. So currently we are doing our own research. We're starting to do our own research, which includes a longitudinal study with people with ME, MS, and healthy controls, where we look in detail about immunology, immune function, including in particular the NK cell function. We do herpes virus infection studies, and we also do gene expressions. So it's a range of studies we do locally and also with some of our collaborators, outside collaborators. And we are very fortunate to have receive a new grant from NIH in the US, which will enable the increase of our participants to around 500. And of course, part of this resource will be used as an open resource for high quality biomedical research. So external researchers willing to get samples and data from us, they go to a process which includes an ethically approved research. They submit to us an application. We have our steering group have a subcommittee who looks into the applications, and then these are assessed after approval by the steering group by the UCL Royal Free Hospital Biobank Committee. And then once all those processes have been progressed, then aliquots are provided to researchers anonymously. And this can be researchers in the UK and internationally. Of course, the main criteria is good research and ethical research. Those are the type of research we are willing to donate blood, or donate part of our resources to. And of course, we will give some priority to projects which are in line with the Biobank's mission, which includes those testing new hypotheses of mechanisms of disease, those looking for biomarkers for diagnosis and stratification of cases, and especially those who have a potential for clinical translation. I think that's what I would like to say. So in summary, I told you about our partnership with Action for ME, and again, thank you very much for all your support, but also the support from MEA and Meruk, who partner with Action for ME to fund some of our studies. And also the partnership with patients, with people with ME, and especially those who provided blood samples and their data and their time to be part of the biobank, as well as those who are controls who don't have ME but are also contributing. So I told you we are in a very exciting time when we are in a position to expand the biobank and in a position to start sharing our resource with other researchers who have a similar vision to us. I'll just leave you with some of our values of our research group. They can be found on the internet, London School of Hygiene and Tropical Medicine. You go to UK M.E. and you can find a little bit more about the types of studies that we have been doing and the sorts of aims that we have at the Biobank. Thank you very much.
Thank you.